So myth number 1, the pelvis is unstable in pregnancy. And again, typically something that I've heard in the clinic before, and I think I would have been guilty of it previously, well, very early on in my career, 20 years ago, using the concept that the relaxin hormone in pregnancy is making your pelvis unstable. Yeah. And again, I think we just need to come out and say it straight away. This is a myth. Yeah. The pelvis is a very stable structure, but this relaxin myth is a real persistent one. And again, it kind of sounds plausible that there's a hormone in the body that's softening the ligaments and joints to create a bit of extra movement. Therefore, your pelvis is unstable. But it's been disproven. Yeah, we've had a systematic review that was in 2012. Relaxin levels don't correlate with pain. And other things that poke hole in this myth is that mums that have a twin pregnancy have 3.6 times the level of relaxin, but they don't experience more pain. And also, everyone has relaxin and not everyone has pain.
That's right. So no doubt relaxin is a very important hormone to help us accommodate the changes of being pregnant. So no doubt that it exists, no doubt that it changes the water content in the collagen to make that space that we need to make to be pregnant. But yeah, the next link with relaxin then being responsible for pain is the part that has been disproven. So need to make sure that we don't think that relaxin isn't having an impact. It is, but it's not correlated to pain. And as you'll see in a few slides time, there's just so many other features that will influence whether a patient experiences pain or not. We just know too much to put it down to one single factor, and knowing that not everyone who's pregnant experiences pain, but everyone who's pregnant will have increases of relaxin.
Yeah. And just back to the concept of being unstable, like the pelvis is a really strong structure. It has to transfer load from the trunk to the limbs. Think about what the pelvis has to do in terms of like loading, or like for athletes, or high impact activity, let alone like its functions for birth. So I think, again, the term unstable should really only be used for like a pelvic fracture, like a high velocity car accident trauma where the pelvic circle is actually broken. That ring is truly fractured. So yeah, I think we can confidently bust this myth.
And that's right. And just to remember, those posterior pelvic girdle ligaments are some of the most strongest in the body, and that's because of the task of transferring loads the way that we do in all the different situations that we do. So really important to speak to that with your patients, that your pelvis is stable. It has some of the strongest ligaments in the body. It's designed to be able to adapt. That's a key feature of female pelvis, is its ability to adapt and pivot to the different situations and bounce back and recover and carry on. So really need to make sure that we're speaking more to that ability to adapt and recover versus the vulnerability of something that we can't control. That's the other trap, I think, if you're speaking just to the relaxin. If a patient hears that and thinks, oh no, I'm doomed because I can't stop relaxin, I think it drives up the fear factor. And we know one of the biggest things that we do is to create safety.
Yeah, for sure. And our Canadian researchers have developed a fantastic infographic, and I've just snapped some pictures here about some key education concepts in clinic, that the pelvis is strong and stable and is adaptable. So this is a great one to use as an education point in clinic. So myth number 2. Musculoskeletal postural changes in pregnancy increase people's experience of pain and can actually impact on the ability for vaginal childbirth. And again, I think it's another one of those biomechanical myths that an increased lumbar lordosis is the growing pregnant belly, increased lordosis means increased pain. So I think we can bust this myth as well. The musculoskeletal changes are definitely necessary and normal adaptations in pregnancy. And again, I think this has been proven across lots of different musculoskeletal pain types and back pain and things, that posture doesn't really equal pain. Yeah.
That's right.
And that your next posture is your best posture.
That's right. Yeah. And not to be vigilant around posture.
Yeah. Correct. So key education clinic from the same research group in Canada, led by Sinead Dufour. This is again the infographic that the key education concept here is safety, that the pelvis is the changes are normal and safe and necessary to support the demands, and that we're adaptable, and that variability is good.
That's right. Yeah.
Postural variability is good.
Yeah.
And having pain in the pelvis and pregnancy-related pelvic girdle pain has not been associated with an inability to have vaginal birth, which I think is a common fear.
Indeed. And I think, again, when that comes up in the clinic, which it often does, you know, can you imagine as a patient, if I have pain in my pelvis, I know I need to have a baby through my pelvis, I feel that that is going to be compromised. So you can understand that women will forward think and catastrophize around that moment. And I just think the research has given us such great data to be able to say, you know what, there's absolutely no evidence that links pain in your pelvis to poor birth outcomes. So straight up, you can dampen down that fear and create the safety in how the woman feels in terms of her capability. Certainly addressing that early on is important, because we know if it continues, those fears continue to sensitize the system, it'll limit your ability to dampen down pain. So I think it's very important to bring that one up as soon as she mentions it, and know at some point you'll need to address it and update her beliefs around about that association between pain and childbirth.
Yeah, it's important to ask those questions. How's the pain impacting you? But what are you worried about? Because this is a very common, projected forethought of, well, gosh, what does this mean for birth and also caring for babies as well.
That's right.
And we've actually got some evidence as well that if you do have vaginal birth, you're actually less likely to experience persisting pregnancy-related pelvic girdle pain. So again, another message of hope and capability.
Indeed.
So myth number 3, we can detect intrapelvic movement in clinic. So this myth is around whether or not we could put our hands on a patient and feel up slips and down slips and movements in the pelvis at the sacroiliac joints or the pubic symphysis. And again, we've got some updated literature from a while ago, so 20 years ago, and then a more recent systematic review to help us bust this one as well. So the fact is that joint movement is really minimal. And again, there's no real clinical test that can make us certain that we're actually detecting actual movement in the joints.
That's right. Yeah, that's right. So that has been proven now that any clinical test that we thought we had that measured intra-articular joint motion within the pelvic girdle is just not credible. The only way is getting little ball bearings into the SIJ joints and doing some sort of X-ray, which of course we're not going to be doing in pregnancy, and the clinical relevance wouldn't even indicate that was necessary. So no doubt that the joints do move. That used to be, the thinking around that used to be that they didn't. Well, they do, but it's small, a little bit more in pregnancy, probably a little bit more in vaginal birth, a little bit more if you have, more babies and more vaginal births, but still these degrees of movement are just so small and indetectable with any clinical test that we have. So important to make sure that you use the right language around that